Pearl Proud has a 25-year-long clinical career. She has held roles as a consulting psychologist working with clients across the lifespan, clinical lead, and the AHPRA accredited clinical supervisor, and that's Australian Health Practitioner Regulation Agency. Pearl is currently overseeing a dedicated called mental health program across metropolitan Perth. So she's working with culturally and linguistically diverse seniors. We also have with us Phil Peladarinos, who was also our guest on our podcast. Phil is the team leader of the social support program team at Mary Health in Melbourne Northern Region. Phil has a background in aged care, mental health, local government, and higher education with over 30 years experience in working with culturally diverse communities.
I'm talking to you from Burulu, which is in Perth in Western Australia, and we are on Noongar land of the Whadjuk people in Western Australia. And I'm going to speak to you as a practitioner, but also as someone who is quite immersed in multicultural and CALD sector in WA, as well as the mental health and the not-for-profit sector. And my talk today is trying to frame something that might come across as a little bit more practical in terms of those of you who are delivering services to older Australians or older people. So the scope that I'm going to cover today is, in terms of the who, we are talking about older, CALD or multicultural Australians. They might be citizens, they might be migrants, they might have permanent residents. Sometimes people are quite new in Australia that we encounter when we're looking after mental health, and also asylum seekers. They might be looked after by other services as well, but you might come across them as people who are older in the community. And in terms of settings, I know that a lot of you across sector, but you are looking after older Australians who might be in aged care facilities, or older Australians who might be senior citizens who are just in the community, who might have services coming to them at home, or who might be going out and accessing services themselves. And again, the scope of focus in terms of the what for me today is just looking particularly at the psychological and clinical aspects, and also not necessarily looking at other support services, because we might have psychosocial offerings for clients that might have a clinical aspect to them, but they also have other support services. So my focus today is going to be on the psychological and clinical side of things. And I'm talking about services that are typically delivered by people like me, who are psychologists or psychiatrists, multidisciplinary teams in facilities who might include other credentialed allied health professionals, social workers, OTs, mental health nurses, etc., and also aged care workers who might come to someone's home to support them with looking after an aspect of their mental health, or who might be in aged care facilities, tasked with looking after all of the needs of someone who might be in care, including their mental health. And there's a different framing in terms of the how for the clinical psychological services that might necessarily include everything that a person might need. And I'll touch on the funding aspects in terms of the monies that are dispensed by the Department of Health and Aging. And also, as you all would know, some of the care can sit inside packages that someone who's older might have that includes all of their care needs. And I'm going to, as I said before, focus on the practical suggestions towards the end in terms of what might be useful as we're looking after a whole person in terms of particularly their mental health. And we tend to come across people who are seeking services or seeking psychological input when they're referred. And so a professional might refer them to services like the one that I oversee, which is specific in Western Australia for CALD peoples, and is a clinical service, and it sits within the not-for-profit sector and looks after a particular set of clients. And I'll talk about that towards the end in terms of what our criteria are. And this provision that we now have with funding that comes to a service such as ours. And people can also come to seek services, clinical and psychological, when their circumstances have changed. So it could be circumstantial that someone might have something that's changed in their lives, and something about their mental health is needing to have particular support. And that can be done because someone is presenting themselves to a place, or there might be a crisis and they end up maybe presenting to an ED, and then that's the pathway through which they might end up seeing someone clinical or someone psychological or accessing a service like ours. So as I said, it's CALD and multicultural older Australians, and the senior citizens can be quite independent, as you would know, and there are people who might be needing some support. So you can have outreach services that might go and look after someone, and someone might have a package in terms of if they're older and they have a particular care package. And sometimes people might have NDIS. There are particular packages that sit under NDIS provisions that might have a clinical or psychological aspect to them. And they are put together so that, again, they're looking after all of the psychosocial needs for someone. In particular, today, we are going to be framing our conversation, particularly with people who might have arrived in Australia. You can have people of multicultural background who are now older, because we've had migration in Australia for a very, very long time. So besides people who are born in Australia, who might be from a diverse background, called multicultural, you would also have people who arrived in Australia, who therefore come with predominantly a culture that's established elsewhere. And they arrive in Australia through migration, either to join family, typically to join family, or they arrive and have worked in Australia for a while before they go into retirement, and then they're older. And then there are people who have a particular circumstance because they come from a refugee background. And the migration experience means that someone that you might see has a particular load that they have that has been shaped by their experience, because migrating is one of those life events that is quite major in someone's life and has repercussions and might have impacts for someone. And as we all would also know, when we see a whole lot of movement around the world at the moment with some of the disputes that are happening, or some of the wars that are happening and conflicts that are happening around the world, there's a whole lot of movement of people coming from one place and arriving at another place. And Australia has agreements through the UN for us to receive people who are of refugee background, and we might expedite their resettlement into Australia. And they might end up being people who are older that we might need to then shape our services to support, or they might only be here for a short time before they transition into care that a whole lot of you might end up providing. Again, we're talking about an age-related cohort here, because retirement in Australia is varied, because we've had it shifting over time. And there are people who might have retired at 55, where people who retire in their 60s, and then people who retire in their 70s. And we see them all as older. But if it's a much, much older age group, then those people are actually in the last sort of, phase of their lives, as they are in aged care facilities being looked after in those settings. And we also have an understanding that people go through different life, through the lifespan, they go through different stages. So again, the cohort we're talking about is specific to people who are in the latter parts of their stages in life, and the needs that they have presenting for them can be quite specific. And we tend to see a certain type of set of presentations for people who are older compared to people who are earlier in the lifespan. The cultural backgrounds can be quite varied. And again, we can match those sometimes through the waves of migration that Australia has had over time. And there are people who are a lot more acclimatized in collectively as a culture or as a group of people who migrated into Australia because they have been in Australia for a long time. Then we have had successive waves of migration in Australia, and the causes for those migration waves also have shifted. And they came from obviously conflicts. Sometimes people were having challenges in their own countries that might not have been violence or conflicts related, but there's a mass migration out of a certain country, and people have come to places like Australia because they wanted to have different lives and they wanted to have opportunities, and they saw Australia as a space where they might come and work. And then you have people who have come through other migration waves from conflict situations, and they arrive with a very different set of circumstances, very different set of family situations, which can be quite complex. And they're also engaging with a culture which is not their own. And there are a whole lot of navigations, if you like, that they have to go through, supported by people like all of us, as they receive the care that they need. And that background also can have the dimension of faith to it. So Australia is a very Anglo-Celtic, country in terms of its culture, the predominant culture, and it's relatively Christian. And you have had migrations of people who come from countries where they have a different faith, which means that how they present as people, how they present their needs, and how they frame their needs, and what their worldview is shaped by the faith that they might have, they're arriving with. And again, this awareness that we as service providers need to have is dictated to some extent by who is arriving in Australia if they come from another country, and the worldview that they might have and the care needs that they might have shaped in a particular way. And again, for all older Australians, we all have a set of history that we might be bringing to the stages of life where we are needing the support and we're older. And so for us as service providers, we need to be thinking quite holistically about someone presenting in front of us and this person who is in this facility or in this aged care home, who has this whole history behind them that they've arrived with. And this is typical also of this age group because they have lived a long time and they've gone through different phases of life, they've gone through different experiences, and they have gone through different changes in the world around them. And sometimes when they are going into this latter stage of needing support, they are again having to go through another transition. And so there's a whole lot of complexity that can sit with someone. And if our view of them and how we're encountering them is not mindful of the fact that there are layers to a person and there's a whole person who has a whole lot of dimensions to them, we might sort of miss something there. And then the final thing in terms of the cohort we're talking about today is the fact that they typically have a family system that they're part of, because CALD and multicultural peoples tend to be part of a family system, and they're not very individual in terms of how the cultures are set, and they are very communal. So there's something to be said for this individual who might be referred, this individual who might be, having a place in a care home, but there's a connection to family which is quite strong, and their sense of identity sits within a family system. And then also the carers that might be part of the service that we are looking after. So we don't look after an individual typically, we're looking after a family, we're looking after carers, we're looking after advocates sometimes of people who are in this latter part and or latter stage of life. And in terms of why people come to be needing mental health support, and the presentations as we all would know, if we are working in the sector and we've been working in the sector for a long time, they tend to be quite typical of the age that someone is. They tend to be quite typical of the phase of life that someone is. And we tend to contextualize them clinically as ones or presentations that are in the latter stage of life or in that stage of the lifespan. And someone therefore might come because they're presenting with a disturbance, a distress, or a disorder, and they happen to be older as well. And sometimes people present because they need to be assessed for something. So a professional, some of you who are caring for someone will be thinking that there might be a need here. There's a case to be made for someone to be referred to a professional to have an assessment of some kind. And it might not necessarily mean that you're going to have, as a professional, a protracted engagement with that person, but you are going to be needing to be quite connected and conscious of the fact that this assessment is going to be in the context of someone who's older and someone from a cultural and multicultural background. In psychology, we've had a very long history of having assessments that have not done very well in being culturally appropriate. And we've had to go through about 25 years, about 30 years of very active activism within the profession for us to be doing better in having calibrated assessments for people who are from diverse backgrounds, because the assessments we typically use in the profession have been normed on very Western populations, sometimes quite male populations, and at times quite young populations. So there's something to be said when we are looking after people who are older and people with a diverse background about the fact that you need to be particularly attentive to and be selective in terms of what assessments we might be using, and frame our reporting and our results with this lens that is informed by being a culturally sensitive practitioner and having an awareness that's broader than just what the tool that you're using might be. And again, there's a distinction in terms of why someone might be presenting in terms of the why. They might come because they just have something mild going on with them. There's a discord in their lives of some kind, and they are feeling a bit sad. Or they might be just a little bit more elevated and having what we'd call a moderate presentation, and they would be having some symptoms that might sit within the categories of diagnosis that we use, or something that's very, very pronounced and quite severe and quite debilitating. And the responsiveness that someone who is looking after an older Australian in this circumstance would need to be relatively quick and attentive to the person who might be deteriorating quite quickly. So the reason why you might refer someone, the reason why someone might be receiving support can be linked to how they're presenting and where they're at in terms of the severity scale. And of course, sometimes things are quite acute and someone might be, rushed into emergency because they're having a psychotic break or something major is going on for them. And when they do present to services and present to professionals, they're going to be assessed, including doing those risk assessments. And risk assessments in psychology are really, really fundamental. We almost do not practice without taking note of risk. And risk, obviously, in terms of someone's well-being and their level of coping and functioning, but also whether they are a risk to themselves and if they're a risk to others. And chronic and complex presentations might be also because someone has been unwell for a long time and they might be having a whole lot of things going on for them, which is why they might be presenting. And again, in terms of timing, there's psychological distress. People usually don't present to mental health services if they're well, unless they just want to enhance their quality of life or maybe talk about their career planning. And the quality of life and relationships. Typically, there's discord and the relationships are deteriorating, which is why someone might present at that particular time. They're not coping very well. And sometimes it's just because they're ready at the stage of life. They want to reflect. They want some support to take stock. And they sometimes are preparing for the end of their lives. And they want to have someone who's going to explore all of that with them. And so when we talk about cult and multicultural clients, we are dealing with a lot of risks and we're dealing with a lot of barriers. And stigma and shame is very typical of cultures other than mainstream cultures. And people tend to be quite reluctant to engage with services because mental health is seen as something negative and something to be ashamed of. So there's a lot of destigmatization that we need to do when we're working with people. And we also have language barriers. We have traumas that people are carrying. Sometimes we have, a culture that's not attuned to the needs that they might have. And it also depends where someone lives in terms of whether they might be able to access service and whether their facility that they're at is going to be offering them psychological support. And then you can have also those intergenerational barriers where, one generation might be seen as not deserving or needing any support. And for you who are working with older Australians, you might be dealing with vicarious trauma, as in any trauma that is happening for someone else affects you. And you might also be triggered when you are dealing with someone who's having a mental health need as you are working with them, and have your own challenges that can come up because you are identifying. You might also be quite tired and burnt out because you've been working with people and looking after people for a long time. So there's something to be said for your own needs and how your empathy levels might be low because you are so exhausted and you are overwhelmed and you are working long hours, etc. And you could also have an environment which is really cynical about mental health, maybe cynical overall in terms of your needs, as well as the clients or the older people that you're working with. And the outcomes that you might then have at the center can be quite poor. And the risks that might happen for the people that you're looking after might be elevated because we are not having any inputs as staff in the space. So what do we do? I'm nearly out of time. I'm just going to run through this because it's quite important. So competent and accountable leadership, as for all of you who might be in leadership positions, we want to skill up in terms of how we are leading spaces. We want to have policies that are really clear, treatments that are evidence-based, etc. And we want to also be mindful of the recommendations from the Royal Commissions, etc., that have been put in place, of course, because they're informing things and improving things. And we want to have CALD and multicultural service delivery that is planned and is tailored for CALD or multicultural clients, preferably delivered by CALD or multicultural clients as well. And then there's the supervision, and make sure that there's professional development and skilling of staff who might not be from CALD backgrounds, but also those who are, so that they can provide adequate service. And then the final thing here is the cultural competency of the whole organization, but also providing facilities as well as modalities like having interpreters on board and having people who are trained to use them. And in conclusion, a holistic approach. So we want to know that mental health and physical health is what life is about. It's not one or the other. And in my view is the fact that we need to be skilled to work with all populations, including older peoples, especially from CALD backgrounds. And it doesn't matter how nice you might be to someone, if you don't have the skill, you might not be able to get outcomes. And we want to also make sure that we follow our intuition. If something doesn't feel right, it typically is not right. And we are all responsible for the care that we offer in this multicultural space. And thank you, everyone.
Thank you very much, Pearl. That was a fantastic presentation, a lot of food for thought for all of us in the industry. Welcome, everyone, and thank you for joining us for this webinar. Today, I'm going to share some of the learnings and experiences as we saw them through the eyes of the social support program during the COVID and the post-COVID period. And that was a quite challenging period for all of us, and it had a profound impact on the mental health, especially of our clientele. And I want to share some of this experience with you. Just to give you a little bit of a background information, the social support program of Mary Health at the time was servicing over 250 people over the age of 65, living predominantly in the cities of Marybeck, Darebin, and parts of Broadmeadows. So it's a quite large geographical area. I just want to set the scene by stating a little bit of the obvious and reminding that social isolation is a state of having minimal contact with others, while loneliness is a subjective state of negative feelings that someone experiences when they have a lower level of social contact than the one that they desire. There are a lot of different definitions for these two terms, but pretty much they are very, very consistent with that meaning. I also want to share a little bit of the impact of social isolation on the elderly, and there is a lot of evidence around that about the effects of social isolation on mental health, especially in increasing anxiety, depression, cognitive decline, Alzheimer's, and so forth. It also impacts the physical health with heart disease, obesity, high blood pressure, and so on. And also, it can lead to feeling tired, increased stress, lack of motivation, having sleep problems, and a lot of other different effects. In 2021, during the period of lockdowns, especially, and in Melbourne we had, and in Victoria in general, we experienced a number of lockdowns. It is safe to say that these lockdowns had a profound effect on the elderly population, and especially people from a migrant background, migrant and refugee communities. A 2021 report from the Ethnic Communities Council of Victoria found that their target population, which is predominantly migrants and refugees, was severely impacted upon by social isolation for a number of different reasons. First of all, lack of family contact. And we know that a lot of the migrant and refugee communities, the family unit is fundamental. And the definition of the family unit extends beyond the immediate family. So being isolated from relatives, even distant, let alone the immediate family, was something that a lot of people didn't cope with very well. Similarly, the lack of local community connection and support. And for people of migrant or refugee background, the community connections are very, very significant. Whether it is the local community, a cultural community, or some other kind of community that they may be part of, once they get cut off and isolated from that, it starts affecting them severely in their everyday life. The lack of religious participation and practice. Again, people not being able to do that the way they usually do, they felt the difference, and they felt the feelings that it was the unknown. They hadn't experienced something like that in the past, not being able to go to a place of worship or be involved in other religious practices. And of course, the reduced access to support services that they may had to access beforehand. During lockdown, there were certain restrictions, or they could not access them at all. And that impacted their health plus their well-being. And one other factor that a lot of us forget quite a lot, but it is very, very significant, and that's the association of lockdowns with traumatic past experiences. A lot of refugees and migrants associate lockdowns and curfews with war, prison, oppressive political systems in their home countries, persecution, and they identify the lockdown or the curfews, situations like that. And that started bringing back memories. And people started reliving experiences of the past that they were very, very traumatic for them. And all this impacted upon their mental health. The social isolation, though, continued, unfortunately, past the easing of restrictions. And it was very, very tough times for people from especially non-English speaking background because of the linguistic barriers, the low level of literacy and formal education, not only here in Australia, but in their own native country, the low digital literacy level. All we can recall is how much we started relying on technology to connect with each other, whether it was a video call or something else. Now put yourselves into the shoes of people who cannot understand that, or they do not know how to operate, or even if they did have digital devices, they use them for a simple phone call and not to video call or for telehealth or all the other beautiful alternatives that we put in place to connect with each other. The introduction of QR codes for a number of reasons, from conspiracy theories to not understanding how it works and not having the device to do that. The fear of infection, insufficient knowledge of the service system, which was in existence beforehand, but at least they had better access. The lockdowns impacted upon the access levels. The cognitive impairment and declining health. All these reasons were added more complexity to the experience of for people from a migrant and refugee background. And of course, it made the impact a little bit more severe. So from the social support program perspective, looking into our clientele and trying to provide services during these periods of lockdown, we started identifying and seeing a lot of changes among our clients. We saw gradually an increasing loss of motivation. We saw an increasing level of personal neglect, poor nutrition and weight loss, increased loneliness, depression. People didn't have anyone to talk, lack of physical activity. And the sleep patterns were very, very unsettled, anxiety and stress. And of course, too much time to think and have a lot of negative thoughts, and which were leading to the fear of death, that what's next for me? Is this going to be the rest of my life? And that was very, very significant. And it was a very big challenge for us as professionals because we were not really trained to deal with all that. And we had support workers that at some stage, they found themselves from one day to the other having to become counselors. And it was a very, very big challenge for our team. We had to put a number of different alternatives and innovative solutions in order to maintain that connection with people. And we started coming up with some different ideas. The fundamental concept was that we had to bring the social support services to the participant's house. So instead of the older person coming to our center, we had to take that to their house. And I'm going to concentrate only on a few service offerings that we developed that we used predominantly during the lockdown period and not when the restrictions eased. The most significant one probably was the wellbeing packs that we developed, because thinking about how can we give people something to do at home and how can we take the social support program to them, we tried to fit all the different activities that we did in a brown paper bag and deliver it at someone's house. So people were fond of craft activities. So we tried to send craft activities home on a weekly basis. people really enjoying talking about life experiences. So that was a little bit of fertile ground for reminiscing kind of activities. People enjoyed doing quizzes and puzzles and coloring, and we started sending a lot of this kind of activities. People liked jokes, or they liked recipes. We had a very, very strong gardening program. We started sending seeds and soil and compost and things like that in little packages to people's houses, and we were doing deliveries. We even had a DVD library, and it was custom made, and different people were having a different combination of items in their well-being pack, and that helped quite a lot. That continued for over 150 weeks. Over 22,000 well-being packs were delivered during that period. An average of about 130, 140 packs a week. It made a big difference. The other part was linking people. We couldn't do that face to face, but we tried to do it over the phone. So we started creating chat groups. We identified the friendships within our participants, and we tried to bring them into contact. And eventually we came to a point that these chat groups became self-facilitated, that all our staff had to do was to dial 4-5 numbers, link the people together, and then off they went, chatting without any intervention from our support workers. And we were doing that with our Greek participants. We were doing that with our Italian participants. We did some English-speaking ones, but the ones that really worked well were the Italian and the Greek ones, because they loved to talk. They had so much to share. They missed so much having that contact with their friends. And these groups were something that we didn't even expect how successful they were going to be. We also ran a lot of telehealth groups. We started training people on how to participate. We overcame that initial skepticism. So people embraced, and they loved their music and their singing programs. They loved the light exercise, which was something that it's a COVID product for us, but it continues until today. We run these light exercise programs on a daily basis. They love their bingo groups and quizzes and gardening programs. And we also had the one-on-one structured telephone support that we developed, that service offering during COVID, and the telephone welfare checks. That helped to make it a little bit easier and break that isolation. It didn't address 100% of the challenges, but it made a significant change towards something more positive for people. And this is based on what the feedback was. I spoke about the chat groups. They made people feel very happy. I just want to go very quickly and share some of the feedback. People used the well-being packs, the information that we were sending them. Someone was telling us how they used the dad jokes to connect with their grandchildren. We had one participant who used to do some of the quizzes and some of the activities over a video call with her relatives in Italy. We had people using some of these activities with their support workers. There was all sorts of different ways that people used the activities of the well-being packs. But what it is more powerful, and I really want to thank the family for allowing us to share this with you. This is one of our participants, Rocco, who is no longer with us, unfortunately. But this is a message that he sent to us one day with a photo. And in a few words, he describes the difference that the well-being packs made for him during the period of lockdown. It was the well-being pack that we sent around Mother's Day with a lot of activities based around that theme. And he has a photo with the positivity jar, which was part of the craft activity that we delivered. He has displayed the magnet proudly, on his fridge, and he's making mention to the bulb that we put in the wellbeing pack with the gardening pack, and he was going to plant that. And this is what it was all about for us. This little testimonial, if you want, highlights everything. That was all about probably 158 weeks worth of well-being packs, all the effort to put them together and deliver them. This is what made the whole difference. And we are very, very happy that we were able to make a little bit of a contribution in making people's lives easier during the period of lockdown. So I will leave it at that. And thank you very much.
I will start with the first question that Michelle had in the chat box, and it probably goes mostly to Phil. Michelle was wondering if dementia exacerbates existing mental health conditions, or if the mental health symptoms of dementia are not connected to existing comorbid mental health.
Look, what we found, I suppose, with our dementia participants, they could not really make sense of what was happening. And for them was a very, very, let's say, interesting and challenging experience because they could not understand the concept of the social isolation and all the different restrictions. And that was very, very hard for them because they did not have the opportunity to get out of the house and engage in other activities. And of course, because of their dementia, they could not participate in some of the telehealth opportunities that we were offering to other participants. So they were restricted in more ways than someone who was cognitively okay. And whether they felt more depressed, I do not know, but they definitely could not make sense of what was going on in their lives. They were definitely more frustrated. That came across very, very clearly, that we saw more frustration and more anger coming from them, and a lot of personal neglect and giving up because they could not differentiate. They had no reason to get out of the house.
Just wanted to respond to Michelle in saying that obviously when assessments are being done for any condition, including dementia, you look at pre-existing everything, and you do a very comprehensive assessment that's going to look at pre-existing conditions or situations or presentations for someone before they get to the stage where they might be presenting with symptoms of dementia. And dementia sits on top of people's psychological function throughout their lifespan. It doesn't come as a standalone thing on its own, but also there are symptoms and there are criteria that are in the diagnostic manual for dementia. So someone has to meet the criteria to be diagnosed with dementia. And then finally, the treatment protocols for dementia are quite set, as in there are certain things that you'd want to be including to treat somebody, which might also then go to enhance the other, the function that's related to conditions that might have been pre-existing. So it's almost like, a person's a whole person, including pre-existing aspects, and then dementia with that, and it tends to be typically comorbid.
What are some of the elements of culturally sensitive assessment in mental health care? Because you talked about that, you called it cultural competency. You also talked about, using interpreter services, the Western style of psychology. So, please, Pearl, what are your thoughts on that?
In the attitudes of seniors or clients who from a CULT background, one of the consistent indications from people from culturally and linguistically diverse backgrounds is that they find mainstream services difficult to access a lot of the times, because they are set up to be receiving people who are relatively mainstream, as in their language, their cultural background, etc. They also indicate that they don't feel seen and heard and understood a lot of the times by clinicians who are not diverse. And there's a lack of attunement to them and who they are and what they need. And they feel that they are not able to access the support because there's a barrier there in terms of them not feeling understood. And one of the things that I indicated in my presentation is that we need to aspire to having services that are delivered for CALD people, because they're calibrated in a certain way by CALD people, as in clinicians who are from a CALD background, because we're trying to across the country to grow the number of clinicians who are of diverse backgrounds, and also in settings that are conducive to looking after people from CALD backgrounds. And it's a response to the indications that people older and also of all ages from CALD backgrounds, that they have barriers for access and engaging in terms of the care they receive.
Are there any specific considerations or advice for mental health care practitioners when supporting older people from refugee backgrounds?
From my experience, I think that helping people from or working with people from different cultural backgrounds, having a little bit of understanding where they come from or what they may have experienced helps quite a lot. And this is why in our line of work, especially with the social support program, when we say that everything is about the relationship with the person that we try to support, this has a very, very deep-rooted meaning behind it. It's about getting to know the person, understanding some of their life experience or what they may have gone through. So then we can relate to them. We can develop that level of trust because we are working with people on a very, very close personal level. The type of support that we provide is, it requires that level of understanding. And also there is an expectation on their behalf that we will deliver a service the way that they would like to receive it. It's about that, what we call the client-centered care. So we need to have a very, very careful approach and try to have a good understanding of the person that we are working with.
In terms of refugees, I used to oversee a torture and trauma service in Perth, which typically had a whole lot of refugees and a whole lot of asylum seekers needing support. So again, this might be very well known to everyone, but there's particular funding, which is federal funding for services that support people of refugee and asylum seeker background. And they've actually just had another injection of funds in the current budget that's just come out, which is really reassuring. But these services are meant to be specific and tailored to people of refugee background, because typically you need to have a trauma-informed approach and work with people understanding all of who they are in the way that Phil was indicating. The world is global, which means that for all of us who are practitioners in all different spaces, if you're going to be looking after people in Australia, we need to try and be aware of what's happening in the rest of the world, because people from the rest of the world come to Australia. So if we understand what's happening in the world, we tend to understand what the impacts might be of people who might come from there to get here. That's usually a news situation on television, discussions in newspapers. We need to try and be connected to what's happening elsewhere, because the world is one. And then the other thing, which I touched on before, is the skill aspect. Skills are what make differences in terms of care. And we want to make sure that we're skilled in areas that we're underskilled in. And particularly attending to people from a refugee background, we want to know how to work with trauma in affected peoples and skill up. These services, which we have one in each city, in Perth, it's called Assets. They deliver training for organizations and for practitioners to look after or have an awareness of trauma-informed care and what tends to present with clients from a refugee background. a good, typically free or very low cost training that anyone can access in the different cities. I think you've got a trauma service in Melbourne, and there's one in every city.
There was one question from Orchidia that was, did you get help of a diversional or recreational therapists in the work that you were doing? So that was during Phil's presentation.
Yes, we do engage people like that we have them as part of our team, and we work quite closely, and we try to develop strategies for people when we develop their care plans and their goal plans. So it's definitely something that we are recognizing as an organization, and we have started having people with these classifications on our staff probably about good 4 or 5 years ago. So it has become part and parcel of our approach in service delivery. And it has made an impact, and it has made a difference. So, we are pretty much dedicated to that model of service delivery.